Inherited glomerular diseases. Alport syndrome. A number of uncommon diseases may involve the glomerulus in childhood, but the most important one affecting adults is Alport syndrome. Most cases arise from a mutation or deletion of the Col4A5 gene on the X chromosome, which encodes type 4 collagen, resulting in inheritance as an X-linked recessive disorder. Mutations in Col4A3 or Col4A4 genes are less common and cause autosomal recessive disease. The accumulation of abnormal collagen results in a progressive degeneration of the glomerular basement membrane. Affected patients progress from hematuria to ESRD in their late teens or 20s. Female carriers of Col4A5 mutations usually have hematuria but less commonly develop significant renal disease. Some other basement membranes containing the same collagen isoforms are similarly involved, notably in the cochlea, so that Alport syndrome is associated with sensory neural deafness and ocular abnormalities. This figure shows Alport syndrome. Figure A, diagrammatic structure of the normal glomerular basement membrane. B, the normal GBM electron micrograph contains mostly the tissue-specific alpha-3, alpha-4 and alpha-5 chains of type 4 collagen. C. In Alport syndrome, this network is disrupted and replaced by alpha-1 and alpha-2 chains. Although the GBM appears structurally normal in early life, in time thinning appears, progressing to thickening, splitting and degeneration. Angiotensin-converting enzyme ACE inhibitors may slow but not prevent loss of kidney function. Patients with Alport syndrome are good candidates for renal replacement therapy. As they are young and usually otherwise healthy, they can develop an immune response to the normal collagen antigens present in the GBM of the donor kidney, and in a small minority, anti-GBM disease develops and destroys the allograft. Now, thin glomerular basement membrane disease. In thin glomerular basement membrane disease, there is glomerular bleeding, which is usually non-visible without associated hypertension, proteinuria, or a reduction in GFR. The glomeruli appear normal by light microscopy, but on electron microscopy, the GBM is abnormally thin. The condition may be familial, and some patients are carriers of Alport mutations. This does not appear to account for all cases, and in many patients, the cause is unclear. Monitoring of these patients is advisable, as proteinuria may develop in some and there appears to be an increased rate of progressive CKD in the long term. Now, hereditary nephrotic syndrome. Many genes have been discovered that cause early onset nephrotic syndrome, often with an FSGS pattern of injury. Inheritance may be autosomal dominant or recessive, the former conditions having a less severe and late onset phenotype and often exhibiting incomplete penetrance. The involved genes almost all code for podocyte proteins, including nephrin, Finnish type nephropathy, and podocin, which both cause early congenital nephrotic syndrome. Autosomal dominant mutations in various genes may cause FSGS as part of systemic syndromes. The genes include INF2, Charcot-Marie-Tooth disease, LMX1B, nail patella syndrome, and WT1, abnormal genitalia, Wilms tumor, mental retardation. Inheriting variants in the APOL1 gene, which is observed predominantly in people of West African ancestry, leads to a greatly increased risk of kidney disease, including FSGS.